Hi again, folks. Welcome to the next video. This one is on assessment and management of dementia, chapter 6 in the J&J. So dementia is a syndrome characterized by acquired persistent impairment of multiple cognitive domains. So it can affect memory, and that's the one that everyone is familiar with, but it can also affect attention, executive function, and it can eventually impact language, visual spatial ability, social functioning, and obviously occupational functioning. So there is a difference between healthy aging and clinically diagnosed Alzheimer's disease, the most common form of dementia. So here you can see we're charting the course of healthy aging, mild cognitive impairment, and Alzheimer's disease. So here's the life course on the x-axis, and you might consider this to be function or ability, or cognitive ability, I suppose. So here at before 40, in Alzheimer's disease, the brain changes might start neurophysiologically decades before the symptoms actually show up. Eventually, there might be amnesic, mild cognitive impairments. So memory problems, other cognitive functions are okay, but memory is first affected, and then the brain might compensate for these changes. Eventually, at some point, cognitive decline accelerates quite a bit. With normal aging, with normal age-related memory loss, this loss in function is not seen. But with Alzheimer's disease, there is a drastic decrease in cognitive function and general function, for example, ability to perform activities of daily living or ADLs. And eventually, there's total loss of independent function. So there is a difference between dementia and normal age-related memory loss. So the DSM-5 in dementia, so the Diagnostic and Statistical Manual 5th edition, has this category referred to as neurocognitive disorders, NCDs. So this includes neurodegenerative dementias, traumatic brain injury, and disorders of a single cognitive domain, such as amnesia. So clinical syndromes are defined by prominent clinical signs, the age of onset, and the pattern of progression. And they are subtyped based on known or presumed etiological or pathological entities. So mild cognitive impairment is a moderate cognitive decline. Mild cognitive impairment, one might say. So it does not interfere with independence, so your ADLs are intact, although greater effort, compensatory strategies, or accommodations may be required to perform ADLs. And this is not due to delirium or some other mental disorder. Major neurocognitive disorder is characterized by a significant cognitive decline from a previous level of performance in one or more cognitive domains. It interferes with independence in everyday activities, so ADLs are impacted, and it's not due to delirium or of some other mental disorder. It's oftentimes associated with dementia or traumatic brain injury, and it's a severe cognitive impairment. Mild cognitive impairment is characterized by subtle cognitive deficits that can be present up to 9 years before the dementia diagnosis. It's a transitional preclinical state, a condition kind of in between the cognitive changes associated with healthy aging and the more pathological changes that accompany Alzheimer's disease. And the person may have a measurable cognitive impairment, but they do not meet the diagnostic criteria for dementia. And the cognitive impairment can be subjectively self-reported and corroborated by a family member, or it can be measured objectively with cognitive testing. With mild cognitive impairment, ADLs are intact. So a person with mild cognitive impairment is at risk for conversion to Alzheimer's disease if the abnormality is found in the alipoprotein E gene, or the ApoE gene. If low beta amyloid levels or high tau protein levels are found in the cerebrospinal fluid, these are biomarkers for amyloid plaques or neurofibrillary tangles, and these result in the loss of neuronal connections and eventually brain cell death. There are some protective factors that prevent that are associated with a reduction in conversion from mild cognitive impairment to Alzheimer's disease. So these are things such as participation in cognitive leisure activities, higher education, and higher socioeconomic status. So these indicate kind of the importance of a lifelong pattern of establishing and maintaining a cognitive reserve. So diagnostic features of other neurodegenerative and other dementias. They are diagnosed by a thorough medical history and clinical testing, which is supplemented by biomarker techniques. So fluid analyses, neuroimaging, genetic testing, such as for the ApoE gene that I referred to. There might be a longitudinal follow-up to determine if these deficits are becoming more pronounced. A definitive diagnosis for dementia is not possible until autopsy, wherein the brain is examined, the brain cells are examined via histopathologic techniques. So thus the diagnosis is given clinically via clinical signs, so behaviors, cognition measured via assessment, various forms of standardized testing via biomarkers, such as changes in the cerebrospinal fluid, neuroradiologically via imaging of the brain structure and dynamic images of brain metabolism, like for example, an fMRI, or structural imaging, so MRI, or maybe even CT scans. Neuropathologically via postmortem analysis of brain tissue, examining pathologic changes in the brain. It can also be examined genetically. Geneticists, microbiologists, and epidemiologists are currently and have been for years studying to determine the origins of dementia, the pathogenesis of the disease. The susceptibility to dementia seems to be multifactorial. So there are interactions between genetic factors, environmental factors, experiential factors, nutritional factors, and other factors. So it's a complicated disease, and we do not have a definitive answer as to the particular cause, and we do not have a cure for dementia at this time. So incidence and prevalence. So there was a important study, the Einstein Aging Study, which was a longitudinal study of 1,944 community dwelling adults, age 70 plus. And they were looking for the presence of Alzheimer's disease, amnesic mild cognitive impairment, and non-amnesic mild cognitive impairment. And they found that the overall dementia incidence was 2.9 per 100 person years, or about 2.9 new cases per 100 persons per year. So incidence rate is a measure of incidence that kind of incorporates time into the denominator. It's basically a measure of how quickly new cases are acquiring over a certain period of time. So the number of new cases per a certain number of people per year. And you can see that in this particular study, it was about 2.9 persons or new cases per 100 persons per year for Alzheimer's disease. And it was slightly higher for amnesic and non-amnesic mild cognitive impairment. The overall dementia prevalence was about 4.9% for Alzheimer's disease, and 11.6 for amnesic mild cognitive impairment, and 9.9 for non-amnesic mild cognitive impairment. So prevalence is the proportion of persons in a population who have a specific disease. And you can look at it at a particular point in time or over a specified period of time. So you could look at point prevalence or period prevalence. But here we're just looking at point prevalence. So how many people have dementia at a particular point in time? And so it was about 4.9 people that had Alzheimer's disease in this particular population. The Alzheimer's Association has some other data. It looks like about 5.4 million Americans had Alzheimer's disease in 2012, according to their report. So that's about 13% of individuals over 65 and 45% of individuals over 85. And the National Institute on Aging estimates that the number of people with Alzheimer's disease approximately doubles every 5-year interval above 65 years of age. The risk of having dementia is higher with advanced age. So preclinical versus clinical Alzheimer's disease. So the preclinical phase of Alzheimer's disease, this is where you have asymptomatic patients, and you might have abnormal metabolic or structural biomarkers, but there's very little actual clinical signs or symptoms in terms of cognitive function. Then there's a clinical phase with behavioral signs of dementia, which a person can be diagnosed with dementia with or without biomarker confirmation. So I mentioned this term biomarkers. So these are parameters. They can be physiological, biochemical, or anatomic. They can be measured in vivo, so in the living person, that reflect specific features of a disease-related pathophysiological process. So, for example, abnormal beta amyloid protein in the cerebrospinal fluid, or hypometabolism during a PET scan, or brain atrophy observed via MRI. So looking at looking at all-cause dementia versus Alzheimer's disease and mild cognitive impairment, you can see that with mild cognitive impairment, there's no significant interference with daily activities, whereas with all-cause dementia and probable AD with evidence of Alzheimer's disease pathophysiological process, there is interference with daily activities. The changes in prior level of functioning differ across these various diagnoses, so preserved independence and functional activity versus decline in the others. There is no delirium or psychiatric disorder associated with any of these disorders. Cognitive or behavioral impairment is observed in at least one domain, possibly in mild cognitive impairment, at least two domains for all-cause dementia. And with probable AD, there's either amnestic presentation or non-amnestic presentation, but memory problems are the most common with probable Alzheimer's disease, and also with probable Alzheimer's disease. There's only substantial concomitant cerebrovascular disease in vascular dementia. And the presence of positive biomarkers kind of depends on the particular dementia as well. If it's present in mild cognitive impairment, there might be increased risk of conversion to clinical Alzheimer's disease. With all-cause dementia, for all types of dementia, kind of depends on the type of dementia. And then with probable Alzheimer's disease, the presence of these biomarkers increases the certainty of the diagnosis, and they're also present with probable Alzheimer's disease with evidence of pathophysiological processes. So this is of note. So positive amyloid biomarkers may be evident 10 to 20 years before clinical presentation. So they can be apparent quite early. So do you remember the figure I showed here? Alzheimer's disease begins to change elements in the brain decades before symptoms start to show. So that is what I was referring to. The positive amyloid biomarkers can be evident years before clinical presentation. Okay, so here we've got a nice figure from the textbook, a differential diagnosis of major dementia types. So we've got Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal lobar dementia. So these were discussed in a previous lecture. Just kind of briefly kind of touch on a few points here. So with Alzheimer's disease, it's clinically characterized by this insidious progressive cognitive disability. Biologically, you can see in vivo biomarkers, so this amyloid metabolism or imaging abnormalities like brain atrophy. Neuropathologically, the brain might show an abundance of plaques and tangles at autopsy, genetic abnormalities potentially. But as I mentioned before, dementia is heterogeneous. The underlying cause is elusive, and a cure is yet undiscovered. So, yeah, it's a terrible disease. So vascular dementia is the second most common dementia after Alzheimer's disease. It's typically caused by white matter ischemic necrosis and neuronal loss and multiple brain infarctions. And the clinical pattern kind of depends on the vessels involved, small versus large, the location of the vascular lesions, and the disease stage. Vascular dementia is unique because it can be identified and treated as the vascular abnormalities can be addressed surgically. So it may be preventable depending on the extent of the vascular issue. Lewy body dementia is associated with three syndromes. So movement disorder, so Parkinsonism, autonomic failure, and dementia. Lewy bodies can coexist with the plaques and the tangles that you see in Alzheimer's disease. So just the presence of these plaques and tangles doesn't necessarily mean Alzheimer's disease. It could also be Lewy body dementia. And common clinical signs and symptoms of Lewy body dementia include shifts in alertness, daytime drowsiness in some people, confusion on waking, and these kind of persistent, detailed, recurrent visual hallucinations. Frontotemporal lobar dementia syndromes. It used to be called Pick's disease, but it's really kind of a family of syndromes. And there's three basic subtypes. So there's the behavioral or frontal variant, the temporal variant, also referred to as the semantic variant, and the left frontal insular degeneration, referred to as progressive non-fluent aphasia. So these subtypes are differentiated by the location of atrophy primarily. So with behavioral or frontal variant dementia, that presents with executive function deficits. With temporal or semantic dementia, that presents with semantic impairments. And with progressive non-fluent aphasia, that presents like Broca's aphasia. That's why it's called progressive non-fluent aphasia. So another nice figure from your textbook, differential diagnosis of major types of subcortical dementia. So we've got Parkinson's disease, Huntington's disease, progressive supranuclear palsy, and Creutzfeldt-Jakob disease. So these are all subcortical dementias, or these are more complex neurological diseases, progressive neurological diseases that are associated with other signs other than just cognitive impairment, but they also have cognitive decline as well. So in the example of Parkinson's disease, you have bradyphrenia, or slowed thinking, executive function deficits, impaired recall, so memory problems, visual spatial disturbances, and depression, so psychological issues. Huntington's disease, psychiatric and cognitive impairments, remote memory impairments. With progressive supranuclear palsy, you have cognitive slowing and attentiveness, memory impairment. So the cognitive impairments are mild relative to the prominent motor impairments, but there are also cognitive impairments. And then with Creutzfeldt-Jakob disease, there's psychiatric disturbances, and there's also impaired memory as well. So these subcortical dementias also have cognitive deficits associated with them. With these subcortical dementias, lesions are primarily in the basal ganglia and the brainstem and cerebellum. Prominent clinical signs are, as you can see, bradyphrenia, or slow thinking, slow cognition, memory and learning impairment, and frontal executive dysfunction. There are other signs and symptoms like motor disturbances, gait and speech anomalies, psychiatric disturbances, apathy, irritability, depression, psychosis, mania, hallucinations. The evolution of cognitive functions can be more rapid than Alzheimer's disease, and isolated aphasia, apraxia, and agnosia are pretty uncommon in these neurological conditions, and other conditions associated with dementia. So dementing conditions can result from metabolic, infectious, traumatic, and nutritional anomalies. So it's not just what you typically think. So Wilson's disease, HIV-related encephalopathy, pugilistic Parkinsonism, like what you get in a repetitive head trauma in boxing and football, other sports injuries, and Wernicke's encephalopathy, so related to alcohol abuse. Cognitive impairments can occur in these disorders as well. So language changes in Alzheimer's disease. So grossly speaking, you could kind of categorize Alzheimer's disease as having an early, a middle, and a late stage. So there will be primarily minor, mild issues in the early stages. So they might have some difficulty with giving instructions, storytelling, being cohesive, some word finding issues potentially. Maybe some problems with complex concepts. Eventually, as you go into the middle stages, you have poor use of worse cohesion, poor use of of nominal reference. Topic maintenance becomes more of an issue. Fewer and fewer ideas are expressed. They rely on more stereotypical utterances. Word fluency becomes worse. Confrontation naming becomes more difficult. Diminished vocabulary. Occasionally, you'll have grammatical errors, difficulty with comprehension of more complex structures. And then in the late stages, you have a pretty much a complete lack of coherence, difficulty with a variety of pragmatic factors such as eye contact. They express few to no related coherent ideas. They use fewer and fewer words and utterances. They're perseverative. They might have automatic speech might be intact, but not that much else. Automatic speech, 1, 2, 3, 4, 5. Hi, how's it going? I'm doing okay. Hello, goodbye. That sort of thing might be somewhat spared, but I mean, there's not a lot of substance to the language. The output can actually be meaningless or bizarre. They can eventually become mute. They might use neologisms, jargon, rambling, grammar. Grammar can be preserved. It really kind of depends on how severe. Like in profound dementia, it's the individual becomes essentially mute, so there's not really much language at all at that point. Very poor comprehension of complex grammatical structures, sometimes poor comprehension of basic grammatical structures, and errors become more frequent phonologically as well. So here's an example of the early stages. So this is a response from a caregiver regarding their loved one with Alzheimer's disease. The main thing I notice is how he's gotten sort of vague, like his thinking is fuzzy or something. He's always been a very precise speaker, but now he hesitates and fumbles and stumbles around. And he misses words. Like this morning when he was talking about getting the car serviced, and he called the car the bathtub. I think he mostly understands what people say, but sometimes he misses things, especially if you tell him several things in a row, like what we're having for dinner or what we need from the store. I think maybe he's not paying enough attention. Here's an example of a caregiver describing their loved one in the middle stages of dementia. We have what you might call conversations, but there's no real connection. You know what I mean? She says things, but it's like there's nothing behind what she says. Thought-wise, I mean, she's pleasant enough, and I'm sure she's trying, but there's nothing there. No matter what we talk about, she says pretty much the same things, empty. And like I said, no real connection. And then the later stages, as I mentioned, there's very little coherent speech and language at this point. And as I mentioned, they can even eventually become mute towards the final stages. And caregivers often report that communication is the single most distressing problem that they face because they have this gradual erosion of sociability. So just having basic interactions, touch, hand holding, hugs, things like that, enjoying food that they used to enjoy, things like that can be sources of comfort, but a lot of the spice of life is gone at this point. So here's an example of a description that a client gave of the cookie thief picture at diagnosis so early. Clinician: now, Miss Smith, I'd like you to tell me about this picture. Patient: well, there's a woman, a mother. She's drying the dishes, but she isn't. She doesn't know that the sink is too full and that it's flouting. No, it's trailing or going onto the floor. She'll notice it when her feet get wet, I guess. And behind her there's two kids, a boy and a girl. The boy is up on a bench, a chair. That's not it, but you know what I mean. And the one there is going to tip over, and the girl is laughing about it. And it looks like the top one there was stealing cookies while the mother is off lost in space. The mother. She's dishing the dishes. Is that what you mean? Here's the same individual at early stage, 3 years later, status post-diagnosis. Clinician: Miss Smith, I'd like you to tell me what's going on in this picture. Patient: I don't care for this one. Can we do a different one? Clinician: let's do this one. It's one of my favorites. I hope you don't mind. Patient: well, all right, if you like it. What's it again? Clinician: tell me what's going on in the picture. Patient: well, there's a woman there and she's up to something. She's not looking at that other there, and I don't know why it's going and going and going, and she's never mind. And she must have had a meal or dinner or something, and she's up to Dishes. Dishes and dishes. I wouldn't know. Is that it? Clinician. Can you tell me a little more? Patient. Well, there's these here little ones, a boy and a sister, little urchins or scapegoats. He's up to it, and she's laughing and all that. And I guess they much be playing some sort of game or contest or something, but it's not clear to me why their mama doesn't look like she's in the game or anything. And that's about all I have to say about that. Same individual, 5 years status post-diagnosis. Clinician. Miss Smith, I'd like you to tell me what's going on in this picture. Patient. This looks like an indelible one, a real American art machine. Clinician. Can you tell me what's happening here? Patient. Yes, I can. They're so scrabble-de-goo that I wonder what all will come of it. They don't have the sense that God gave a goose, if you ask me. And I don't know why that other one there is not in the measure of this one, but it doesn't matter because this one here is laughing and playing, and I don't know why you never know about them these days. But anyway, if they were for me, I'd have to squelch and anoint that one there because I can't stand it when there's such chess and murder. Is that what you mean? So this is, yeah, these are typos here. So that was in a moderate stage, and here we have a late stage. Miss Smith, this picture tells a story. Look at it and tell me what is happening in this picture. Patient, never mind. Clinician, can you tell me what is happening here? Patient, I said never mind. Clinician, Miss Smith, can you do me a big favor and tell me what's happening here? Patient, oh, all right. It looks like somebody lost the way and was the other way, not under and over, but ambulation. Clinician, can you tell me anything more? Patient, that's the usual something for under and over, and that's all. So, roles of the speech language pathologist. Speech language pathologists play a primary role in the screening, assessment, diagnosis, treatment, and research of cognitive communication disorders, including those associated with dementia. So, our roles might include identification, so identifying people at risk for dementia. We assess, so selecting and administering clinically, culturally, and linguistically appropriate assessments. We intervene, so we select and administer clinically appropriate evidence-based practice therapeutic techniques for direct intervention with persons with dementia and indirect intervention through education of caregivers and environmental modifications. We counsel individuals, so we provide individuals and their caregivers with counseling about the nature of dementia and its course. We collaborate with other healthcare professionals as well as caregivers to develop intervention plans for maintaining functional communication abilities at the highest level possible. And we manage cases, so we can serve as case managers or coordinators or team leaders to ensure that the delivery of the management care plan is performed. We educate both the patients, the families, the caregivers, and throughout the course of assessment, diagnosis, and treatment. And we also educate other professionals and the public regarding the communication needs of individuals with dementia. We advocate for our patients. We advocate for services for people with dementia. Sometimes we have to fight with insurance companies to make sure we get coverage. And we perform research, so advancing the knowledge base of these cognitive communication problems and dementias and their treatment through research. So this is the application of the ICF model to individuals with dementia. So we have this health condition, Alzheimer's disease, that affects body functions and structures. It affects activity participation. There are environmental factors that have to be considered and personal factors as well. So one should consider all of these components. You might begin an assessment by asking questions. So what has always been the most important thing in Sarah's life, for example, if Sarah was the patient? How do you think Sarah would like to spend each day? How do you want to spend your day? With what do you need help with as a care partner? Who else can you count on to be a care partner for Sarah? Well, what is going very well for Sarah and you right now? And what's not going so well? So the most frequently family or caregiver reported problem behaviors were repetitive questions, things like, where's my wife? What time is lunch? Restlessness or pacing, I need to go home. Where are we going today? Delusions and hallucinations, something that's relatively common in some forms of dementia. You are not my husband. There's a construction crew in the backyard, and loss of interest in activities. So relative to assessment, it's important to observe visual behaviors, auditory behaviors, tactile behaviors. So pay attention to how they respond to various visual stimuli, how they respond to talking, to noise, to music, how they respond to touch, to distance, proximity. It's important to identify the daily communication challenges that they experience, the skills that they need to accomplish the things that they want to accomplish functionally in their life, and to try to train those skills embedded in the context that it needs to be embedded in for them to perform it. So this is just an example of the difference that a change from 16-point type to 72-point type might make. So obviously you're going to want to go for a larger font for an individual, especially if they have visual deficits. And contrast is important too. So if you're printing it on something other than just a white background, you have to consider the color of the text that you're using. Always consider the contrast. This is an example of a personal interest and needs inventory. So these are good things to do in terms of finding activities that that the patient likes to perform. So things that are functional, things that are relevant for them in their life. So not just ADLs, but other things as well. It's good to learn a little bit about them. And one might be interested in creating a memory book, for example. So you're going to want to include these kinds of things in a memory book. So their childhood home, place of birth, high school, college, if they were in the military, what occupations they might have, special honors and awards, places that they lived, places that they visited, if they belonged to any clubs or social organizations, if they had any church involvement, their favorite pets, favorite vacations, who did they go with, their best friends, their obviously their family is one of the main things too that should be on there. So a detailed family kind of outline, present challenges, daily schedules, routines, likes, dislikes, interests, hobbies, physical, emotional pain, needs, medications, safety precautions, fall precautions, eating precautions, personal hygiene precautions, all of the above. So all of this stuff is very important to acquire. With assessment, you're obviously going to want to review the medical chart to rule out potential medical causes. There are some dementias that are, well, they seem to be presenting like a dementia, but they'd actually might be due to a medication. And I've actually had a few patients that were like that, where their cognitive function improved markedly after the medications were changed. If there is hearing loss, there might need to be a request made for audiological evaluation, or check the hearing aids to see if the batteries are working, or check the hearing aids just to see if they're working, period. If they have them, they might not even have hearing aids, so maybe they need them. You will want to focus your attention on interviewing the care partners and systematic observation of the communication of the patient and the communication between the patient and their caregivers. Note if there's any abnormal behaviors present. And just look at the patterns of communication with regard to time, place, duration, partners, topics. And with respect to responsive behaviors, identify, describe, and count the frequency of the care partner and resident complaints. So see what are these abnormal behaviors and when are they happening? Why? Maybe try to get down to the root of the problem. Why are they having these issues? So here's a recording tool for determining the frequency of responsive behaviors. So you can describe the behavior and the context. You can count the problems, where it occurs, when it occurs, that sort of thing. There are these things called life interest and values cards that are good resources. So these, the website there is supplied. This is a pictorial support for individuals with restricted communication ability, and to indicate activities and life participation, which is most relevant for them. So you might have them look at the card here and then ask them a few questions using this algorithm here. So do you do this now? So for example, maybe it would be talking to people. So do you do this now? And the answer might be no. Do you want to start doing this? They might say, yes, I would like to start talking more with individuals. So this allows kind of direct communication with your client about valued life activities. You can facilitate goal setting and in everyday in assessments and in everyday conversations. Clinicians' activities must acknowledge and actively address the entire environment of care. So the physical environment, the social environment, and the professional care and family environment. With patients with dementia, because it's a progressive degenerative disease, the goal, unlike with other populations, is not generalization of skills across contexts. We don't really expect improvement in overall cognitive function. We do expect improvement of communication in very specific contexts, so situation-specific training. So working on workbook type activities will not be very helpful in these patient populations. We need to train the patients in specific skills and specific contexts. So here are some assessment instruments for dementia, some standardized assessments. So generally, assessment should include a case history, neurologic and medical diagnostic battery, clinical examination, behavioral assessment, and language and communication assessment. So here we have a series of language and communication assessments. So here are some screening tests, scales and inventories, neuropsychological and psychiatric tests, cognitive linguistic, and language tests. So the ones that I am most familiar with are the SLUMS and the MOCA. Those are the most common ones used in our skilled nursing facilities. So here are some interventions for dementia given in the textbook. So caregiver education, cognitive stimulation, computer-assisted cognitive interventions, reality orientation. This one, you might want to tread lightly here, because some patients, if you orient them to reality, especially towards the modern, the later stages, because they don't retain that orientation, they just get a sense that they are deeply unhappy and upset and they don't know why. So I would actually tread lightly on reality orientation, just in my experience. In some cases, it's actually best to go with the patient. Simulated presence therapy, reminiscence therapy, this is a good one, where this oftentimes will utilize a memory book. And I've done this many times with many different patients, where you create a memory book, and then this also includes photos of family and vacations, favorite memories, favorite people. And so you can spend some time reminiscing about past friends and past events. That's a great one. And then, of course, spaced retrieval. Here is an example, case example. So Mr. Smith. Mr. Smith was diagnosed with Alzheimer's disease. He's got a mid-stage. He's 83 years old. So he was at this particular facility, status post knee replacement. He also has comorbid chronic obstructive pulmonary disease. He has asthma. And he successfully lived in long-term care setting for 14 months. So he was referred to speech language pathology services due to decreased orientation, refusal of showers, general restlessness and boredom, and significant change in his participation in activities. So relative to documentation, you will need to have documented a prior level of function. So to document the decline in the orientation, the participation in group activities, and ADL independence. There should be some statement of risk related to safety. So the patient is at significant risk for safety concerns due to decreased orientation and increased agitation. There can be a statement related to quality of life. So the patient is at significant risk for decreased quality of life due to new onset of social isolation. And there should be some kind of a statement of kind of a reasonable expectation of improvement. So multiple scientific studies support the use of print and other graphic cueing systems to increase orientation and quality of life. And decrease negative behaviors in clients with dementia. So external memory aids for increased orientation. There might be a justification for the length of time that therapy might be administered for. So the client will require at least 4 sessions of 30-minute treatment with direct training of certified nursing assistant for appropriate generalization and transfer techniques. And so relative to the therapeutic approach, we want the therapeutic activities to be meaningful. So they have to have an impact on the quality of life and decrease negative behaviors. And if you're using an external memory aid, you want it to increase orientation, independence, and safety. So that's kind of the goal of the memory aid. When you walk into the room, it's good to have a pen and paper and pen handy. Make sure that the resident can see your face, speak clearly, use short sentences, stress key words, write them down, or over-articulate, Repeat yourself if necessary. Moderate loudness, no yelling. So not too quiet, not too loud, moderately loud. Use gestures if appropriate, and you're going to want to eliminate all external distractions. So turn down the TV, radios, etc. You want a quiet space. So Mr. Smith, he loves to change and count money. He loved casinos. You could provide him with paper rolls to wrap change. Please sort for us the following amounts. So you might give him this money to sort in a sorting task. And you can try this in both more public and more private spaces with cue cards for task completion to kind of deal with varying levels of environmental distraction. All right, here are some examples of external memory aids. So here, the clock is kind of where he can't see it, so it's not really doing a very good job of orienting him. So it's out of view, and the table's a little bit messy. We've got some things kind of the table's a little bit messy. And here we've got a better setup. You can't really see it from the picture, but he could see the clock much more easily. And you can also see this reminder to call Leanne at 1 p.m. You can also see his calendar. So it's a much better setup, much easier to see. Here's some more external memory aids. So a showering prompting setup here for external memory aids. And here's one for him to put his dirty clothes away. So prompting for placement of dirty clothes. All right, so measuring outcomes. So how will we measure outcomes? Well, you could converse with the STNA, kind of collaborate with the nursing assistant through use of shower logs. You have to train her on how to do that. You can follow behavioral incident reports, like are there more or less behavioral incidents reported? You can do an orientation assessment. You can chart track functional communication exchanges. What is their accuracy on open or yes/no questions? Are they able to complete ADLs with less prompting, maybe even independently? And you could use various and sundry tools like this observational measurement of engagement, where you explicitly chart or you explicitly track times offered, started, and finished for activities. And then you can kind of rate using this kind of Likert-like scale of a non-attentive to very attentive, a very negative attitude to very positive attitude. And response to treatment. The client referred to external memory aids for orientation to the environment and to activities. The client referred to his external memory aid to increase independence in his ADLs in performing his activities of daily living. The patient increased orientation when cued to use the external memory aid. The patient increased independence in showering when prompted to use external memory aids. The patient increased participation, engagement, and attention to the activity, given mild verbal prompting, for example. Here are some STNA quotes. The resident has been very depressed lately, but he enjoyed something to keep his mind busy. The resident enjoyed being able to do someone a favor. The resident is remembering his needs to call Leanne. Clock and calendar seem to be helping him keep oriented. Resident was able to complete a shower himself after a reminder to use cards. Resident felt proud. And a fun resident quote here. Look, I have a job. My payment is pills and coffee. All right, well, thank you so much for watching this video. I will see you in the next one.